Okay, well, good afternoon, and thank you for having us for this webinar. We are very happy to be here to share with you a little bit about developing partnerships with public health and local organizations. Um, in introducing myself, my name is Henry Cunningham, and I serve as the Assistant Vice President for Engage Scholarship in the Office of Community Engagement. And I'll let my colleague introduce himself.
Hello, everybody. I'm Nicholas Piper. I'm an associate professor in the Department of Epidemiology and Population Health and a staff scientist in the Eating Anxiety Treatment Laboratory. And thank you again for inviting me. And yeah, looking forward to a great presentation and discussion.
All right. So we listed a few objectives that we hope to cover during today's session. What we hope to do is by the time we're finished is have an idea as to what exactly is a community. Kind of look at some of the what are some of the common elements of a community partner and working with them, and also some of the best practices that we can identify in developing and sustaining community partnerships. So these are the three things that we hope to accomplish by the end of today's webinar. But first, what we'd like to do is spend some time talking about community engagement and defining what exactly community engagement is. This is very important because the definition of community engagement really defines what this work is. It's the foundation of what this work is. The University of Louisville uses the Carnegie definition of community engagement, which states that this work is a collaboration, and this collaboration is done in a mutually beneficial way. So as we think about the work we do, whether it's teaching, it's research, it's outreach, it has to be mutually beneficial. And this work is done with a partner, and it's done in a form of partnership and reciprocity, so that we all benefit from this work. I share this definition because there are many different groups now that uses the term community engagement. The city has a person that oversees community engagement. Humana has a person that uses community engagement, and different groups now have people who oversee community engagement. But the way they define it is a little bit different from the way it's defined in the academy. I think in the community, these organizations use community engagement to refer more to community relations, which is quite different from engagement. With engagement, we're talking bilateral work. The work, there's a collaboration and there's mutual benefit in this work. So I want to share this definition because it is the foundation of what we do. If we are working in the community and we are collaborating with a partner, the work is mutually beneficial, then we are not doing community engagement. We are probably doing something else, but it's not community engagement. And I really want to emphasize that. In moving on, I think it's also important that we know what a community is. And I pulled this definition from the University of North Carolina, Greensboro, who is, they have a really robust community engagement program going on their campus. And they define community as what is external to their campus. And it has to do, it's national, it's local, it's state, it's global, and it's work that is done with nonprofit businesses, civic agencies, and schools. Very, very clear, very concise. That is exactly who your community is. And I think it's very important that we are aware of who is our community when we think of this work. Here at UofL, we also have a definition of what a community is. And so on the next slide, you will see UofL's definition of what is a community. Again, we use the term any entity or all entity that is outside of the campus. And I emphasize outside of the campus because sometimes people say, well, no, I am doing work on the university campus. I'm doing some kind of project. Is that community? Is that my community? And I say it is a community, but in this context, it's not the kind of community that we are talking about. We're talking about a community, an entity that is outside of the university's campus. And these may include, again, nonprofit businesses or any government organization. That is what we mean by a community partner. Any groups that is outside of our campus walls. Okay, so I want to make sure we are clear on those definitions. What we hope to do during this presentation is share a little bit about some of the best practices based on the research in community engagement. What's some of the best practices that the research states that we should have when we are developing and maintaining a partnership? And then we want to talk about some practical examples, ways how those partnerships have been developed and sustained over the years. So firstly, I want to talk about elements of a successful partnership. Again, this is based on the research. And according to Brian and Henry, they claim that if we want to have successful partnerships, there has to be shared values, which means your values need to be the same as the values of your community partner. Whatever you believe in, if you strongly believe in something, that is where you want to find some partner that share those same kind of values, whatever those values are that you want to work on. Likewise, there has to be a shared vision. What is your vision for the community? What is your vision for your teaching? What's your vision for your course? What's the vision you have for your research project? Whatever you are doing. Though that vision has to be in alignment with your community partner as well. The same applies to goals and objectives. What do you hope to accomplish at the end of the project? Because you're working in collaboration with each other, therefore you need to support each other. And so the goals, objectives, vision, values all have to be aligned with yours and that of the community partner. It's important too that you have an understanding of what each other want. What do you want out of the partnership? What exactly do you need out of this partnership? And what is of interest to you? Those are very, very important. Again, if you don't want the exact same thing, there will be some tensions. There'll be tug of war because you will not be working to address each other's needs, wants, interests. So it's important that those are all aligned. And likewise, there need to be shared practices and experiences. So whatever practices you are involved in need to be, again, that of your partner, and whatever experiences you like to accomplish needs to be aligned also with your community partner. So these are some elements that need to be present in any partnership for it to be successful. Brian and Henry shared this 7-stage model, and they said in every partnership we should follow this model. And this model, they have 7 steps in this model. And the first thing they said is we need to prepare to partner. And what they mean by that is we need to do our research. We need to find out what our needs are, what our wants are, what our interests are, whatever those are, and find out who in the world can help us to get to where we want to be. So you've got to do some research and some preparation before you get out there and find a partner. You've got to assess your needs, your strengths. What are your needs? What do you want to accomplish? What can you do really, really well? What is your expertise? What kind of resources you have? And these are all things you need to do before. And then once you have done that, then you need to go and find who in the community is aligned with what you want to accomplish. Then you come together, and you talk. Okay, I tell people this work is like dating. You've got to talk. You find out, you see a person to whom you're attractive, and you talk to them. You want to talk to get to know this person. So with your community partner, you want to start talking. So you come together and talk. You get to know each other, and this is where we start to develop trust in each other. Once we talk and we know what each other want, then we can start to create a vision and a plan. You talk about your wants, your needs, your interests, and then you can work on developing that plan or that vision that you have. Once the plan has been developed, you've talked about it, you both agree this is what we want to accomplish together, so this is what we want to work on together, you can then take action. You can take action and implement your plan. And you have all the pieces put together in implementing this plan. Once you have your plan implemented, the next stage is to evaluate this work. How are we progressing? Are we on track? Do we need to revise and pivot because of circumstances that may have changed? So you need to spend some time to evaluate the partnership, the project, before you continue. And whatever successes you have, you want to celebrate those successes. And then the last thing in this seventh stage plan is you want to maintain momentum. And maintaining momentum means you want to make sure we don't lose interest. We are constantly communicating. We're talking about the work. We're making sure that we are doing what we're supposed to be doing, and we are strengthening the relationship. We are strengthening the partnership, the collaboration that is happening. So you want to make sure you maintain momentum and you don't lose interest in the work that is being done. Okay. As we move to the next slide, I want to talk about Hudson and Hardy's research. And they talk about 6 principles of university community partnerships. And principles is, can we call them like, successful elements or whatever. Again, different people call it different names. But what we are trying to show you here is that there's similarities among all these different concepts, these models, so to speak, that different researchers have come up with. And they provided 6 principles. And the first of these is the acknowledgement of the need for partnerships, which is very similar to what I talked about earlier on about preparing to partner. You acknowledge that you need to partner with somebody, and you have a project you would like to do, but you realize you cannot do this project on your own. And so you do an assessment to determine what you want to do, what needs to be done, and with whom you could perhaps partner to get this project completed. Secondly, you want to make sure you clarify the purpose of the partnership. Why are we getting together? What do we hope to accomplish? What are our roles and responsibilities? That has to be clarified. So we need to define what your roles are and also the roles of your partner in working together. No ambiguity. Otherwise, that can lead to confusion. Thirdly, there has to be a commitment from both of you. No, a commitment to this work, a commitment to this project, a commitment to success. And that is very important. Each person is committed to what is being done. Next is the aspect of development and maintenance of trust. And I can't emphasize trust enough. For us to partner successfully, we have to trust each other. And you only get trust over time. Trust is not something that we can get overnight. It only comes after a prolonged time of talking and being together, getting to know each other. Many times faculty come to my office and they're writing a grant proposal and they want me to help them find a partner in the community. And I said, in reality, what we should have been doing is we should have been cultivating partnership, some time ago. And together, Union Partnership have said, here's what we want to work on together. And can we find a grant to fund this project? That's in the best case scenario, that's the way it should be. So we should be working with people, developing these relationships well before we determine what exactly we want to work on. That's really one of the best practices. So trust comes with time, but it's something we need to work on, for quite a while before it is established. Next, it's important that we talk about clear and robust partnership arrangements. What is the arrangement? Where will this project take place? How will it be done? Who will be involved? All the details need to be worked out. So when we are working with our partners, it's important that we work on all of these details. So everybody knows what each person's role and responsibilities will be. So it's very important that we take time to talk about this work in detail. Monitoring, reviewing, again, very similar to what I mentioned earlier on from our previous model about commitment to this work and evaluating the successes. You got to monitor what's happening. You got to monitor regularly to ensure you are on page. We're supposed to be doing, and we review, on a regular basis to make sure that there's no need to make changes. And if there's a need to make changes, then we have time to do so before it's too late. So again, 6 principles of the partnership development that we can use to define work. And then the last model here is is of Hudson and Hardy, Carlton and Whiting and Bradford and et al. And they call theirs essential factors for collaboration. That's what they call their model. And again, there'll be some repetition here. Again, mutual respect we've seen before, trust we've seen before, clear and common goals and vision we've seen before, dialogue communication we have seen before, developing the partnership, nurturing the partnerships. Again, we've seen that before. We got to develop the partnership and we got to nurture the partnership. Because again, got to keep talking to make sure we can maintain momentum as we saw in the previous model. Involvement again comes up. Again, that's the commitment, and again, regular communication, and that we are involved in this work. And then the last one here is prioritizing the community and maintaining community focus. And this one is very important because as faculty members, we tend to prioritize our own research, our own project. We tend to prioritize, our data gathering, our publication, data collection, all that stuff to get scholarly products. And we tend to give the priority of the community as a secondary point. And it's important. This work should be mutually beneficial. This work should be reciprocal. So there needs to be a need for there to be equal priority to your scholarly endeavors as well as the needs of the community and your community partner. And that is very important because in the academy, that is one area in which we tend to be rather guilty. And so I want to make sure that I emphasize that part. Okay, so as you develop your partnership, here are a few questions you need to ask yourself as you develop your partnership. What am I interested in doing with a community partner? Okay. If you're doing research, then that's something you want to consider, or you may be thinking about your teaching a course and you're placing a student in the community as part of the course requirement, or maybe it's some kind of co-curricular engagement. So why are you interested in collaborating with a community partner? And then once you've identified that, you want to think about who in the community may be able to work with you. They have a similar interest to host students, to work with students, or engage with you on a research project to find the answers to a particular question. And then once you've done that, then you need to think about what should be my next step. So again, it's a quick overview of what developing a partnership should be. So what I did here is to provide you a quick overview as to what the research is saying as it relates to developing and sustaining partnerships. And so next we will shift gears a little bit and we will talk about some of the practical ways that this work has been done. And my colleague Nick will then take it over from here.
Well, excellent. Thank you so much, Dr. Cunningham, for all of those foundational principles. And as I talk about some of the work that I've done as an epidemiologist and worked a lot with various communities, all of the principles that you talked about apply here. And they're so necessary to successfully work with a variety of community partners. So what I wanted to do as an epidemiologist is quickly talk about some of the perspectives that we've had in the field, particularly over the past 50 years, and how we have focused predominantly on a biomedical approach. This has been really great in doing a lot of risk factor epidemiology, understanding etiological mechanisms, understanding causal factors of disease. But where we've been moving really over the past, I'd say 10 to 15 years is emphasizing multi-level systems. So we've identified these risk factors, and that is incredibly beneficial to clinical care and practice. But there might be structural issues that need to be changed and things that we need to take into consideration when implementing public health programs that really address those risk factors and causal factors at the population level. So this is what has been called consequential epidemiology. So it's taking that next step and making sure that we translate our knowledge about causal factors into practice. So as part of this, dissemination and implementation science are absolutely key. And as you can see here, community partnerships are absolutely critical for engaging with populations and making sure that we have shared goals in improving health, and we're not just engaging in a top-down process without that community-based input. So what I'm going to talk about today are some of the work that I've been doing over the past 15 years and a lot of the lessons that I've learned. So I'm going to talk about my work in Ireland with an organization called Jigsaw, the National Center of Youth Mental Health. I'm going to talk about a campaign, social marketing campaign, health promotion campaign called Live HIV Free. That was centered around engaging with people who use and inject drugs and addressing infectious disease, particularly during the COVID pandemic when testing and other sorts of services were interrupted. And then also some of my work in West Louisville, particularly around vaccine equity and how that work is actually being rolled into some diversity in clinical trials work. And then I also want to plug the Eating Anxiety Treatment Laboratory, where I do a lot of public health approaches to addressing eating disorders. We have some work with the Kentucky Eating Disorder Council. That includes some components of community partnerships and community engagement, but it wasn't as directly applicable to these three topics. So I'm going to just stick with these three, but did want to mention that a lot of these principles are being applied in the eating disorder work that I've been doing over the past 2 to 3 years. So transitioning into Jigsaw. So this was an organization that was created as part of a public health response to really poor youth mental health in Ireland after the 2008 financial crisis. We were seeing quite a lot of morbidity and mortality related to poor mental health, some of the highest rates of suicidality among youth in the European Union. So there is a clear need to address a lot of the disparate services that currently exist, that existed at the time, a lot of wait lists, just a lot of young people that really needed care but couldn't receive care. So Jigsaw was founded through support through Ireland's National Health Service, as well as through donations from several prominent health foundations. And what was so cool is that Jigsaw involved the rollout of community-based services and supports for youth throughout the country. And there is a catchment of about 500,000 young people throughout Ireland that these services served. So This was sort of done on a regional level. At the time that I was doing this work 15 years ago, there were 10 youth mental health clinics that were co-created with young people and service providers and other community members. And each one of these regional clinics and support places was tailored to that particular community. So there's this overall jigsaw model, but adaptations that were made based upon the various needs of communities. And so, for example, in Dublin, this was, of course, the major metropolitan area, whereas other places were more rural. So there are some urban-rural differences, other sorts of cultural adaptations that were made depending on the characteristics of that particular community. So as I started doing this work in 2010, 2011, I was blessed with the opportunity to travel a lot to Ireland and really talk to a variety of different stakeholders, young people as well. And one of the lessons that I immediately learned was that multi-sector partnerships are absolutely essential. So this meant talking to physicians, nurses, social workers, people who work in various health services agencies, other sorts of social services agencies, administrative staff from schools, even local businesses who had quite an interest in this domain, particularly because they had family members and young people in their families and extended families who were impacted by the financial crisis and were really experiencing poor outcomes related to youth mental health. So really, this involved quite a lot of focus groups traveling all throughout the country, sitting down, having extensive conversations and building rapport and trust. And particularly as somebody from the US coming to Ireland, that trust building was incredibly important because there were initial perspectives that I was an outsider and my colleagues were outsiders, and rightfully so. So we had to kind of dispel a lot of that being an outsider, but still being dedicated to addressing this problem together and as a team. And then really just talking through problems that they were seeing in their communities, problems that they were experiencing in their various services, and really suggestions that they had around how to best address youth mental health and being very strategic. So not just coming up with high-level ideas, but coming up with tangible strategies that could be built upon over time. Another important lesson was to involve youth in the decision-making and planning process. I think a lot of times as professionals, we come together, we talk about these things, but we can have a tendency to be very top down and make some really important decisions about how to best address something like poor youth mental health. But it was really important to bring young people to the table. And each community that we work with, we form these youth advisory panels. And that was really interesting to hear problems from their perspectives and really get insights into the lived experiences of these young people and how they were trying to cope with poor behavioral and mental health. So they gave us ideas on even like what these youth mental health centers and clinics should look like. How should we design it? The color of the paint of the walls, the layout of everything, how staff should engage young people. So without that input, I think we would have been successful in rolling out these sorts of youth mental health clinics, but we might have ended up missing the mark on how to best really engage with youth and take their needs and preferences into consideration. As Dr. Cunningham mentioned, it's really important to evaluate these things over time. So this is, as an epidemiologist, this is what I particularly got excited about. This was very data driven, making sure that we were using validated measures when young people do engage with care, and if they wanted to get a brief intervention. So that was typically like 3 to 5 goal-oriented sessions with a trained mental health provider. So it was very important to have standardized measures of depression, anxiety, psychological distress, and show that the sorts of services that were being provided to young people were actually centered around their needs, and it wasn't just these one-size-fits-all approaches to care. We were really being rigorous in terms of our intake assessments and making sure that the care that we provided to young people was personalized. And at the bottom, you can see some of our outcomes evaluation studies that were conducted to show this. So what was so exciting was that it was a preliminary validation that Jigsaw was indeed personalizing care based upon the various needs that young people had. So, for example, certain young people might have had more internalizing symptoms, so more along the lines of depression and anxiety, and we wanted to match them with services that specifically address those symptoms. Whereas other young people had more externalizing problems, so they were having conduct issues and running into problems at school and at work. So they received more services that were focused on anger management and behavioral change and whatnot. So that was very important in this process to make sure that everything that we were implementing was personalized to young people's needs and community needs. So now moving along to the work that I conducted about 3 to 5 years ago, called Live HIV Free. So this was a public health response to increase HIV among people who inject drugs in Louisville during the acute phases of the COVID pandemic. This was in partnership with Louisville Metro's Syringe Services Program. And part of this included involvement of PWID in the planning process, as well as program implementation. So at the time in 2021, we were seeing wide-scale interruptions to HIV testing and other sorts of services. And rightfully so, was making this population very nervous about how they address a growing problem, especially since Louisville Metro is an HIV epicenter. We've been hit hard by the opioid crisis and the overdose crisis. So it was really important to come up with a solution that this population would be amenable to. So some of the lessons learned, and a lot of these lessons we were able to learn by having listening sessions with the population. So as I previously mentioned in Jigsaw, just avoiding that tendency to do things in a top-down fashion and saying, okay, well, there are these HIV self-testing kits. We can just distribute these and people will use them and we'll be able to really increase testing as services come back online during the pandemic. It was more of a bottom-up approach. We wanted to create a safe, non-stigmatizing environment for this population to convene with us and just talk through what they're experiencing, what they're seeing on the streets, and present something like HIV self-testing to them, and really just asking them the best way to roll it out. Is this something that you want as like a standalone type service, or is this something that you want integrated into other sorts of harm reduction services? So think naloxone distribution, safe drug use kits, fentanyl test strips, and those sorts of things. And it ended up being the latter. They wanted this to be another tool in the harm reduction toolkit, and have this be one of the many things that they turn to have more control over their health, really address a lot of the stigma that they have experienced in medical settings around being a person who injects drugs and is at ultra high risk of acquiring HIV and other infectious diseases. So we wanted to make sure that the procedures that we came up with wouldn't reinforce some of the stigma and issues that they had experienced. Another lesson learned was that we needed to establish industry partners. So even though these OraQuick products were commercially available for about $50, we had a need to purchase thousands of these kits. So it became cost prohibitive at first to just kind of take that commercial approach. So in working with OraSure, who manufactures the self-testing kits, we were able to reduce those prices and really increase the number of kits that we were able to distribute. But what that meant was that we had to create a lot of our own instructions. But again, that was an opportunity to engage with community members and this particular population to come up with graphics and pamphlets and provide instructions in ways that wouldn't be off-putting for this population. Another big lesson that we learned was being ready for pushback. So when we started rolling out this program, we weren't aware of this obscure Kentucky statute that actually made it a Class C felony to purchase, acquire, and otherwise distribute these HIV self-testing kits. This came as a big surprise to us. It's kind of like one of those laws of you can't have ice cream in your back pocket to like tempt horses and steal horses. So this was like never really enforced. And at the time we were really confused because you could just go to Walgreens or any local pharmacy and buy these kits. But I think that this was indicative of some community pushback around this program and differences in perspectives and how to address infectious disease and other sorts of adverse health outcomes in this particular population. So that posed a lot of issues to successfully implementing Live HIV Free. The last lesson here is that sustainability is easier said than done. So this picture on the left is of an organization called the Social Practice Lab, which was working under the Louisville Metro SSP umbrella. But unfortunately, after this program, there wasn't continued support for the Social Practice Lab, so that location shut down. So as fast as we can implement these programs, there can be issues with sustainability. But fortunately, this work has been really instrumental in passing some state legislation and even having the Cabinet for Health and Family Services adopt these HIV self-testing procedures. So even though that there are some problems with the Social Practice Lab, we've been able to sustain the self-testing through other organizations, through other legislation, and through a lot of state health programs. And that's exactly what is shown here, and how important it is to build evidence to engage with policymakers. So a lot of the work that we did in Live HIV Free actually served as the scientific foundation for House Bill 349, which was passed in March of 2023. You can see to the right of Governor Bashir is Michelle Rose, who is the other principal investigator on this project. So really rewarding to be able to run into a lot of implementation barriers, a lot of fear in the community that happened because of that, but we were able to leverage that and turn it into policy change, and subsequently have a lot of community-based organizations in the Cabinet for Health and Family Services adopt the HIV self-testing procedures and protocols that we came up with. So those are all prominent on CHFS's webpage and other local organizations, and these test kits continue to be distributed as part of a big harm reduction toolkit that has Narcan and test strips and other sorts of tools to reduce the spread of infectious diseases and reduce overdoses and other sorts of adverse health outcomes. So lastly, I want to touch on the West Louisville Vaccine Equity Project that I did in collaboration with Norton Healthcare, their Institute for Health Equity. So this was work that took place from 2022 to 2024, funded through the CDC to address health disparities and increase health equity and health-related outcomes resulting from COVID and other forms of preventable disease and infections. And you can see the three goals of the project here were to create a community advisory board who define the parameters of vaccine acceptance and uptake for residents in the targeted localities. So there were 5 specific zip codes in West Louisville that we were really targeting. And we promoted vaccine acceptance and uptake using adapted messaging that the CAB really took leadership in helping us develop. And then we implemented multi-level vaccine awareness interventions in coordination with that CAB and other key community partners. Some big lessons learned here is being ready for criticism and being put on the spot. As you can imagine, there's quite a lot of medical distrust in this community. So that trust building was really important, and showing a willingness to take that criticism. And a lot of the times we want to try to provide a scientific rationale as to why certain things are happening. But this was more just about being humble and taking that criticism and connecting with CAB members as human beings, and understanding that yes, there have been missteps in the medical and public health communities, and we hear you, and we are experts at certain things. But what we're not experts at are defining the needs and priorities of your community. So we want to provide the platform for you all to define those sorts of things. And that's exactly what we tried to do with the program, in providing multiple platforms. So this was digital. So we had a widespread social media campaign. We worked with a Black-owned company based out of DC to help with rolling that out. CAB members also did like personal interviews, providing their stories around COVID, how afraid they were, some of the hesitations that they had around the vaccines that were coming out and how fast that they were coming out, and addressing those issues of distrust, but giving them the opportunity to really tell their stories and share about their lived experiences, in hopes that their stories could reach other community members in West Louisville and help guide their decision making around vaccines. We also attended a lot of health fairs So we worked with Norton's Prevention and Wellness Program, several of other Norton programs to get out there. So having a kiosk and a table set up, giving out evidence-based materials around vaccines, directly engaging with people, helping them navigate so they can find where to get a vaccine in their neighborhood. So that was really important. And then also Faith and Health Ministries at Norton was instrumental in us engaging in churches and other sorts of local organizations that are particularly important in this community. So all of those three things were instrumental in successful implementation of this program. But of course, there were a lot of challenges with managing a large cab. So we had about 15 people. I think at a high level, everybody was on the same page in terms of wanting what's best for their community, trying to work together with the public health and medical community to address those needs. But there were definitely some differing perspectives on an individual level on how we do that, what the messages, what the specific messages should look like. So that was a little bit unexpected in terms of just having to address like some interpersonal differences and really make sure that everybody stays on the same page. Keep reiterating our shared vision, our shared mission, and not letting things essentially get derailed. And then logistically, just implementing multi-level interventions with community partners can be very difficult when you get down to it. So having to work with CAB members and their schedules to conduct those interviews, making sure that we were scheduling everything and coordinating everything properly with all of the various entities at Norton. There were about 15 to 20 various community partners and organizations that we were working with. So there's just a lot of like logistical challenges that go into doing that. So definitely have that in mind as you're thinking about these sort of community partnerships and making sure that you take time to take deep breaths and just understand that it's not always going to go exactly as planned, and things need to be very dynamic, and you need to be able to pivot and shift what you're doing if all of a sudden you think that you're going to a bunch of health fairs and scheduling changes. So, okay, what else can we be doing at this time? How can we quickly convene the CAB to make sure that they're going to be okay with it? So really just having to stay on your toes and be flexible in order to properly deliver these sorts of programs in the community. A big lesson that I want to emphasize with this vaccine equity program is to maintain your connections. So about half of the CAB has been rolled into a new CAB that is focused specifically on diversity in clinical trials. So this is a project that I'm collaborating with Norton on to increase representation of racial and ethnic minorities and other historically underrepresented populations in their clinical trial work. So there is a community engagement, community partnership component to this work. Again, similar sort of approaches to the previous projects that I was talking about of getting that community voice. So we've been doing some qualitative interviews with people all throughout Louisville from a variety of racial and ethnic minority populations. And the CAB was instrumental in designing the interview guide. What sort of questions should we be asking people? How should we be asking those questions? et cetera. So again, if we would have taken that top-down approach, I think we would have come to a certain set of conclusions. But it's great integrating that bottom-up approach and getting that community input, that community buy-in, and increasing the likelihood of success in terms of getting the information that we need to increase awareness around clinical trials, what are understanding some of the different the cultural differences throughout Louisville, and how do we address those differences and make adaptations as we try to get increased representation for certain populations. So this is ongoing work. Really excited about that. Really thankful to have that continued community input. They've even provided some input around some of the more data-driven aspects of what we're doing, how to look at outcomes, particular outcomes that we should look at, particular metrics that we should look at. So really, the community partnerships have been instrumental in having a 360 view of how to best address this long-standing issue of lack of diversity in clinical trials and clinical research. So from there, I think we can go ahead and open up to Q&A. So looks like there are some questions already rolling in, and then I will stop the sharing. So feel free to go into the chat panel and yeah.
Looks like we have a question from Alania. What strategies do you employ to foster trust within the community? Do you begin with some talks? Are focus groups considered?
Yeah, I think from the standpoint of the work that I've been doing, a lot of it is just listening, and the urge is to try to talk about the science, come up with rational explanations, but those can be helpful at times. But for me personally, I found that it's very helpful to just say, I hear you, and I'm here to listen. I'm not an expert in what your community wants and needs. So I want to make sure that you have an opportunity to share that and tell us how we can best integrate all of that into the programs and interventions that we're about to implement. So in my experiences, that is definitely fostered trust. It's showing a willingness to accept that we're not perfect, even though we're doctors and highly trained. There are missteps and gaps in our work, and we want to do everything that we can to work with the community to fill those gaps, so we aren't just reinforcing them over time.
I would like to add to that too, that it's important that you spend lots of time with your partners. Frequent visit, lots of visit. You cannot spend too much time with your partners. Trust is only developed over time. And so the more time you spend together, talking, visiting, spending time together, that is how trust develops. You've got to get to know each other. And so you've got to spend time together. So the more visit you can, make into the community and talk with people, the more you will get trust developed.
Yeah. And specifically with the Vaccine Equity Project, we had monthly CAB meetings. We tried to schedule them around people's work schedule and family schedules. We provided food. We also had monetary incentives to account for the fact that some people were driving long distances. So that was another way to show that we respected the fact that they had to sacrifice time and resources to come to the table.
While we're waiting for additional questions or comments to come in, I'm curious, when you're putting together a panel or a focus group, is there an ideal amount of people that you would want to include to ensure that you get the majority of the perspective covered? So I know that there are numbers like that, for example, in user interface testing. So I'm just curious what that
Mhm.
looks like for focus groups and panels in particular for research.
Yeah, I'd say focus groups and listening sessions. I mean, probably 7 to 10 people. And then if there are large audiences, then having multiple focus groups and listening sessions. Um, I think any more, not that having more or less doesn't work, but you can, particularly when you have more than that, you can run into issues with certain members of the focus group talking more than others, and then you find yourself as a moderator having to call out certain individuals to make sure they have a chance to participate. So I've kind of found that sweet spot is around 7 to 10 people, and you can elicit good engagement and good information with that amount.
Okay. And then I have one other question, and it's sort of so if you're new and you're just starting this kind of research, and it sounded to me like there's a very reiterative process as you're going through um, designing and conducting this type of study. How exactly do you approach or work with the IRB and this kind of, are these studies typically like retrospective? Are they upfront? How does that work?
That's a great question. Yeah, a lot of this work in terms of public health programs and quality improvement programs don't necessarily meet the criteria for human subjects research. So that can be really beneficial in just being able to immediately start implementing something. However, in scenarios where you are doing more formal data collection, whether it's in-depth interviews or focus groups or even like quantitative surveys, that is good to that's a situation where it's good to like have some correspondence with the IRB and make sure that none of that rises to the level of human subjects research.
Okay, that makes sense. All right, well, I don't see any other questions coming in. I guess I can go ahead and ask my last question. I'm curious, what color was the best? I'm assuming, is it red for the room? When you have a focus group, you said like what color the room? No, did I misunderstand that?
Oh yeah, so yeah, for Jigsaw, I mean the some places wanted like murals and yeah, I can't remember the particular colors, but it was more just trying to engage with local artists, and there were a couple communities where the young people were actually able to engage with a couple local artists and draw some murals and other sorts of things themselves. So it was really fun to
It's
just
interesting.
give them the autonomy to design the space and what was going to be most comfortable for them.
Yeah, that's really cool. Okay, well, thank you both so much for joining us this afternoon. It's been a great session. And for those on the call, I will follow up in an email with a link to a recording of the session and a survey. So thank you so much for attending, and we'll see you for our next seminar in the CBPR series at the end of January.
Thank you for having us. Thank you.
Thank you so much. Yeah.